Okay, we're going to talk about pediatric tracheostomy care. Okay. The objectives of our discussion today is to list the common indications for tracheostomy insertion in children, describe different types of tracheostomy tubes used commonly, outline how to manage the perioperative period when tracheostomy is inserted initially, and safely manage emergencies and how to take care of tracheostomy in children. So, common indications for tracheostomy, probably the most common indication is airway obstruction. Quite often it's done for upper airway obstruction, and this craniofacial syndromes are probably the most common types of airway obstruction for which tracheostomy is done. This is like there is facial anomalies which lead to. Do we start our lecture now? I already started. Join. Are you ready? Yeah, join. I mean, how long can I wait? There are other people also participating, no? They are waiting. Yeah. So, so these craniofacial anomalies, they have malformations of mandible and stuff like that, maxillary bone, and as a result have a narrow upper airway, and the children might struggle to breathe right from birth. Quite often these patients need tracheostomy in the neonatal period or very early after birth. Other causes of airway obstruction could be neck and laryngeal masses, cystic hygroma, and so on, which is kind of obstructing upper airway, subglottic stenosis and supraglottic stenosis, congenital or acquired. Subglottic stenosis is very common after preterm birth and neonatal ventilation. So this is probably a big group of indication. The second group of indication for which tracheostomy is done is long-term ventilatory support. So this could be due to chronic lung disease, for instance, chronic lung disease of prematurity. It may be due to muscle weakness secondary to neurological conditions like spinal muscular atrophy or other forms of muscular dystrophy, where the patient has weakness of the muscle, respiratory muscles and diaphragm, usually all the muscles, but in particular the ventilated support is for weakness in respiratory muscles and diaphragm. In some cases, the neurological conditions, patients may have depressed respiratory drive. The congenital hypoventilation syndrome is a condition where the patient has poor respiratory drive whenever they're asleep. So these kind of patients are okay as when they're awake, but when they go to sleep, they go into apnea and sometimes can have sudden infant death syndrome. Also other airway obstructions like tracheobronchomalacia may increase the work of breathing, and these patients may need PEEP and respiratory support to help with their breathing, to support their growth and development, and so on. Another group of patients is protection of airway, and just a moment. Hello. Hi. Yeah. Who? If she's not feeling nauseous, yes. If she's not feeling nauseous, vomiting, she can. If this morning she was feeling nauseous and vomiting, why don't you come here, guys? Yeah, she can eat. She can eat. Yeah. She has a sensor implanted. Okay, so every hour the nurses need to read the blood glucose of it. Okay. Yeah, there is a sensor which is implanted in the patient. Okay. The mother. Is that right? Until it is there, we need to monitor hourly by finger prick. Okay. 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 Yeah. After 4 hours, yeah. Okay. Okay. Thank you. Bye.
It's the same link for the teaching, isn't it?
Yes.
Yeah, the same thing.
Okay, so sometimes the patient has had cardiac arrest and hypoxic ischemic encephalopathy or trauma, head injury. Head injury, then the patient may be encephalopathic, may have bulbar palsy, may not be able to handle the secretions, swallowing and may not be that good. In this case, for airway protection and prevention of aspiration, sometimes we do tracheostomy. Many times, this kind of patients, when they are, with recovered and with time, and if there is neurological recovery, they may be able to be decannulated later on. Another indication is failed intubation. Sometimes patients have difficult airway unrecognized, and then they go to OR for a surgical procedure, and the anesthetist is unable to intubate the patient, and there is a situation where the patient could not be intubated or could not be ventilated as well. In that situation, also tracheostomy may be done to have a safe airway for surgery and procedure and so on. This is a patient with Pierre-Robin syndrome. This is one of the types of craniofacial anomalies that I mentioned in the last slide. In this patient, usually there is underdevelopment of the mandible. So there is retrognathia. So you can see that the chin is very retracted. So as a result, these patients have significant upper airway obstruction. And other conditions like Beckwith-Wedman syndrome, where the tongue and the tongue is very large, also they can have obstructed airway. And these children will struggle to breathe soon after birth. Sometimes they are intubated, and if they can't, if they fail extubation because of the upper airway obstruction, then tracheostomy may be done. So these patients are amenable to surgery, but the surgery is going to take time, and it can take years before the reconstruction is complete. Until that time, they may need tracheostomy. So you can see in this patient, this jaw retractor has been implanted, and this is like the same baby in different ages as the baby grows. This distractor is kind of, moved apart, helping the growth of the bone, the mandible. And you can see the jaw has now almost developed to normal extent. And this patient now is decannulated because the airway is now much improved. So these patients with craniofacial abnormalities and upper airway obstruction may need tracheostomy for a long period of time, even few years, until the reconstruction is complete. So what is a tracheostomy tube? A tracheostomy tube is inserted from skin in the neck, and it goes into the trachea. Okay, so this is to bypass the upper airway mostly, but also sometimes to provide ventilation, sometimes to wean the patient off the ventilator, sometimes to have a safe airway, and so on. It's done. So you can see the anatomical area, like there is the thyroid cartilage, and then there is the cricoid cartilage, and then the tracheal rings start. And usually the tracheostomy hole is made between like 2 and 4 tracheostomy rings. So not the first one, but the second, third, or fourth tracheostomy rings. In that area, the surgeon makes a hole, and then he inserts a tube. And this tube is left in place for a good few days so that a stoma or a tract will form from the skin to the trachea. And once this is well formed, it stays open. And if you take the tracheostomy out, it will stay open for a temporary period of time, usually for a few days. But it will become narrower and narrower as time goes by, and it may shut. So the if you have to replace the tracheostomy tube, because it's a very quick process, this stoma will stay open. You can remove the tracheostomy tube and replace it. Okay, so the tracheostomy tube can be cuffed or cuffless. Okay, we will talk about this a bit more. So how is the surgical tracheostomy done? Here is a illustration with various landmarks marked. So you can see this is the sternal notch, and this is the cricoid cartilage, and midway between this, the surgeon makes an incision. So he has marked it out where to make the insertion, and then he makes the incision, and he dissects down to trachea. You can see here that the trachea is now visible. So before they make a hole in the trachea, they put these stay sutures, one on each side. The purpose of this is if you pull them apart, then the trachea will come up and it will become close to the skin, and then you can insert the tracheostomy tube. This is usually kept in during the perioperative period, maybe for a week or so, because if the tracheostomy tube accidentally fell out and the tracheostomy stoma is not well formed yet, you can use these stay sutures. By pulling them apart, the trachea will come up and close to the skin, and you can put the tracheostomy tube back. So you can see here now, it's the first time the surgeon is doing the tracheostomy. In this instance, they are pulling the tracheostomy stay sutures, and the trachea comes up to the surface, and then the surgeon will insert it. Once the tracheostomy tube is in and secured, the surgeon will stick it on this side and mark it right and left. This is really important because if you mix it up or cross it over, if you pull them apart, you may be actually closing the tracheal hole. So it's really important to keep this marking and these stay sutures on the right side. Because I know of one instance where in emergency, they took the label off and then accidentally they swapped around and they tried to use the stay sutures, pull them apart so that they could insert the tracheostomy tube, but they couldn't, and the patient had a cardiac arrest. That was because it turned out that the sutures were crossed over and they were pulling, and actually instead of bringing the trachea up and open, this suture was then closing the tracheostomy hole. Also in this instance, the surgeon has stitched the trachea with sutures to the skin to form a fistula already. Many surgeons are doing this recently because this reduces the risk of accidental tracheostomy. If the tracheostomy got dislocated accidentally in the perioperative period, like in the first day, second day, if you don't have these sutures, sometimes it may be difficult to replace the tracheostomy tube. If the surgeon uses this kind of sutures to stitch the trachea to the skin, then the stoma is much more open and stable. So many surgeons are doing this to reduce the risk of the tracheostomy falling out and then having an airway emergency in the first few days after tracheostomy. So this are the parts. This is the tracheostomy tube. This is actually an adult tracheostomy tube. This yellow bit here is the inner cannula. Usually the pediatric tracheostomy tubes don't have an inner cannula. They only have one tube. And here usually you have a connector that will connect to the ventilator or bag valve mask circuit or whatever. So this is the flange. The flange has like holes through which you can pass the tracheostomy tie to secure it in place. And the cuff is there, usually towards the end of the tracheostomy tube. And this cuff inflation line enables inflation of the cuff. So these are basically the parts, and the tracheostomy tube is shaped in such a way that it has a smooth angle into the trachea, And if you're passing a catheter and stuff like that, there are no acute angles that has to be bypassed. Okay, there are many different types of tracheostomy tubes. We will talk about two common types that we use in pediatrics, Bivona and Shiley. So the Bivona tracheostomy tubes are made from silicone material. So this is an inert material, so it doesn't cause too much reaction with the skin and so on. They are available in pediatric and neonatal sizes. They have different kinds of flange, a V-shaped flange and a straight flange. They claim that this V-shaped flange is advantageous because you can secure the tracheostomy much better with the V flange. I don't know. Personally, I don't feel this makes a huge amount of difference, but that's what the manufacturer claims. They have uncuffed and cuffed types. The cuff, they call it tied to shaft. What that means is, we will see in the next slide, when the cuff is deflated, the tracheostomy will function almost like an uncuffed tracheostomy. Usually when you deflate the cuff in an ET tube or a tracheostomy tube, there will be a little bit of crinkled cuff that is stuck to the tracheostomy tube, and it causes a bit of a rough surface. But in this tracheostomy, they have made it, they have improved the design in such a way that if you deflate the cuff, it looks almost like an uncuffed tube. It is inflated with, the Bivona is inflated with sterile water because silicone is gas permeable. If you put gas in, it gradually leaks out. And usually you use a minimal leak technique. That means you deflate the cuff and you inflate the cuff, like injecting a little bit of water at a time until there's only minimal leak left. They also have a type called air cuff, which has a thicker cuff. It's also made of silicone, but because it's thicker, it is not that gas permeable, and you can use air to inflate it. And this is also available in pediatric and neonatal sizes. An important aspect to note with Bivona is it's wire reinforced. So MR images may be distorted, especially if you're doing an MR of the neck and upper chest, then the tracheostomy tube can interfere with the quality of the images. You can still do a MRI of other areas like brain and stuff like that because it's MR conditional. But wherever, the area closer to the tracheostomy tube is usually very distorted. So if you want to do a neck or upper chest with a Bivona patient, you have to change the tracheostomy to Shiley so that it's not interfering with the images. They have another type called flex tent, which got extended length proximal shaft. I will show you a picture in the next one. And this one helps because it keeps the ventilator connection away from the flange, and they claim that this causes less pressure and damage to this tracheostomy site. So this is Bivona uncuffed. This is a V-shaped flange that they say is very advantageous. This is a cuff tube, but you can see the cuff is not visible at all. It's deflated now, and it almost looks like a uncuffed tube. The advantage is that if you insert this, it acts like an uncuffed tube, and if you have to ventilate the patient and stuff like that, you need it to be tight, and you can inflate the cuff. Having this tube in gives you flexibility of inflating whenever you need, compared to this one. If you have this patient and the patient has an infection, lower respiratory tract infection, and so on, and the lung compliance is low, then you may need to replace the tracheostomy to a cuffed one. So if you have this one in, you can leave the cuff inflated, and if the patient needs ventilation, you can inflate it. This is the flex tent. You see here the connector is very close to the flange, but in this one, this connector there's a gap between here and here, so there is nothing pressing on the skin when the tracheostomy is secured. So, and also the ventilator circuit is connected here, and it's not rubbing against the neck and the chin and so on. So this may be an advantageous. You can see what wire reinforcement means. You can see the little wire that is there to strengthen the tube and prevent it from kinking. Okay, because it's wire reinforced, it interferes with the MRI. So this one is a Bivona air cuff. Again, this can be inflated with air because the cuff is made of thicker silicone. And these are generally the sizes. They have pediatric and neonatal. Usually the neonatal tubes are shorter compared to the pediatric tubes. As you may imagine, the neonate is smaller than the baby and the child. This is the next one, Shiley. So the Shiley is made of PVC, and they also have cuffed and uncuffed tubes, and they also have the flange slightly V-shaped. So these are the different sizes of neonatal tubes. They are almost similar in the length to the Bivona tubes. So usually you can, replace them one with the other if required. So these are pediatric sizes. So they have like an extra long type as well. So if you have a patient with tracheomalacia or something like that, or tracheal stenosis that you want to bypass, then you can use the extra long cuffless tubes. They also have extra long cuff tubes as well. So these are there. Sometimes the standard ones are too short for that patient. Say if there is an obstruction at the lower, closer to the lower end of trachea, and you want to bypass it, then you can use the extra long ones. So what size to use? So usually for a small baby, it's 2.5, between 1 and 2 kilos, 3 millimeter. Newborn age to 6 months, 3 to 3.5 millimeter. 6 months to 12 months, 3.5 or 4. And 1 to 2 years, 4 to 4.5. After that, you can use the same formula that you use to calculate the size of the ET tube and use the same size tracheostomy. So when to use uncuffed tubes and when to use cuffed tubes. Uncuffed tubes are preferred in children without need for mechanical ventilation or prevention of aspiration. If the patient needs mechanical ventilation, it's better to go with a cuffed endotracheal tube. So if you're inflating with air, you need to make sure that the cuff is the pressure required to kind of prevent leak is below 30 centimeters of water. The lower it is, the better it is. If you're using water, usually only 2 to 3 ml of water is required. If you're having to put more water or inflate it above 30 centimeters of pressure to prevent the leak, then you should consider upsizing the trachea. That means you go up one size. If you have a 3 cuffed, go up to 3.5 cuffed. And it's also important to follow manufacturer instruction when you're managing the cuff. So if if the manufacturer recommends you inflate it with water, please do so. Okay. Humidification. So this is really important because when we put tracheostomy, we are bypassing upper airway. So the upper airway normally causes, humidification, and it also warms the air to closer to body temperature. So usually 80% of the humidification is done in the upper airway, and you're bypassing it. So if you don't humidify or warm the gas, it can damage the tracheal and the mucosa of the airway and so on. So if you, especially, if you have a tracheostomy, you need to kind of think about how to do the warming and humidification. There are usually two types. One is you can use humidified gas. So for this, you need a humidifier, and the gas has to be, humidified at least to 30 to 40 milligrams of water per liter. So fully humidified gas has like 44 milligrams of water per liter at 37 degrees. But because there is some more humidification that happens in trachea, you can just use 30 to 34 degrees, and humidification at that temperature. If you're using a humidifier, you would get this amount of humidity. If the patient is on mechanical ventilator, it's better to use active humidification using a humidifier. If the patient is not on ventilator, you can use a heat moisture exchanger, which is like a little filter. And as the patient breathes out, the moisture and the heat is captured in the device. And when the patient breathes in, the air takes in the heat and moisture from that humidifier, HME filter. This is passive. It is probably okay for unventilated patients. So this one, the slides are in wrong order. So I talked about this Shiley. The Shiley is made of PVC, and the cuff is inflated with air, and it's MRI compatible. So now we will talk about how to care for the tracheostomy. The stoma site needs to be looked after, because if it's exposed to moisture and there is pressure, it commonly contributes to pressure device associated complications, which is like granulation tissue and skin breakdown and so on. So it's important to assess the skin quality and pressure ulcer risk on a regular basis. So the extended tracheostomy tubes may provide an advantage because the connector is away from the flange. Then, the pressure on the skin around the stoma may not be that much, maybe slightly less than other, if you have a connector close to flange. To prevent the moisture from being there at the site of the stoma, it's recommended to use hydrophilic barrier between the skin and the flange. The hydrophilic barrier will absorb the water and keep the skin dry in that area. The skin should be cleaned, and then this hydrophilic barrier or moisture wicking material should be changed daily. But depending on how much secretions and stuff is there, you may have to do it more frequently, at least once, but more often if required. If there is a lot of secretions and this hydrophilic barrier is getting wet, then you need to change it. So how to change the tracheostomy tube? You have to make sure that you have appropriate equipment at the bedside. You have to have the same size trachea tube and one size smaller. You need to have all this equipment: oxygen, suction catheter, pulse oximeter, bag valve mask. An obturator is like an introducer that goes into the tracheostomy that makes it stiff for it to be, inserted into the trachea. Water soluble lubricant and tracheostomy ties ready. Usually 2 people are required, so you need to ask for help. If use a checklist if you have one in the unit. So before you start, you do a full assessment, have a listen to the patient, make sure the breath sounds are equal and there isn't too much secretions there. Document all the vital signs. Then make sure you suction the trachea to be sure that the secretions are clear. Ensure proper lighting. Put a roll under the shoulder so that the neck is slightly extended. Then you release the tie and you replace the new tracheostomy tube and secure the new tracheostomy with the tracheostomy tie. After you finish doing this, you have to suction the tube again just to make sure that it's not there are no secretions pooling. So the tracheostomy ties, most often we are using this Velcro type because this is softer and thicker in that it doesn't dig into the skin. So when the tracheostomy tie is, in place, it should not be too tight or too loose. It should allow slipping of one finger between the skin and the tie. If it is too tight, it needs to be released. If it is too loose, it needs to be tightened. The rate of skin breakdown with this type of Velcro tie is less than other types, like the cotton ties are there, but they are narrow and they can dig into skin. So what if you're having a patient with tracheostomy in the unit? What are the equipment that you need to have by the bedside? So you need to have oxygen supply, suction and suction apparatus, and the right size suction catheter. So you can usually multiply the size of the internal diameter by 2 to get the appropriate suction catheter. A bag valve mask should be readily available. An end-tidal carbon dioxide calorimetric device. Here it is. So this is helpful in checking if the tracheostomy is in good place, like it is within trachea or not. If there is carbon dioxide coming out in the exhaled gas, this will change color to yellow. So this helps you to confirm that the tracheostomy is in good position. So it's better to have one at bedside. You should have spare tracheostomy tubes, same size or one size smaller. Tracheostomy ties, if you have to replace them, scissors, lubricant. Tracheal dilator is here. This tracheal dilator is used to keep the stoma open if you have difficulty inserting the tracheostomy tube. Say you're replacing and it's difficult, then this may help to kind of keep the stoma open and then insert the tracheostomy. A catheter mount this is the catheter mount which you can connect to the tracheostomy and connect the bag valve mask to the other end and use it. If you are in the ward and you don't have a good light source, in ICU you always have a good light source. If you don't, then it's important to have a pen torch so that you can have good visibility, and a 10 ml syringe which is used for deflating or inflating cuffs. Sometimes you can even use this for if you are stuck, you can use an NG tube and 10 ml syringe to suck the tracheostomy out. To make the tracheostomy care safer, especially for a new tracheostomy and old tracheostomy patients, it's important to put up a bedside sign saying that the patient has tracheostomy, providing all the essential information that you may need to manage the patient in case of a tracheostomy emergency. So this includes the type of tracheostomy tube and the size of the tracheostomy tube, the internal diameter, and whether it's cuffed or uncuffed. And if you're using suctioning, then what size suction catheter is used and what is the length of the suction catheter that you need to insert for proper suctioning. It's also important to say if the patient has a patent upper airway or not. This is important because as you saw, a patient with a craniofacial anomaly or an abnormal upper airway, it may be difficult to intubate the patient. It may be difficult to bag the patient. So this is important, and the airway may be obstructed. And these patients, if the tracheostomy falls out, may be at a higher risk of having complications such as inability to insert the tracheostomy back and cardiac arrest and so on. So if the patient has upper airway difficulties, then you need to say if the patient can be intubated orally, and that anybody else has intubated the patient orally and has been able to intubate, and is the patient able to be ventilated with bag valve mask in the usual fashion. These information will help whoever is at the bedside to manage the tracheostomy emergency. And also you need to be aware of how to call a code. In BMC it's 4 5s, and you have to tell them the patient's where the patient is, patient's location, and whether it's pediatric or adult. So how do you know if the patient is in trouble, if the tracheostomy patient is in trouble? So if the patient has significant respiratory distress, subcostal intercostal recession, struggling to breathe, noisy breathing, whistling sound, all of these things suggest that the tracheostomy is obstructed. The child may also be restless and sweating and tachycardic because it has to kind of, there's less, increased effort of breathing, and the patient is getting agitated because the air doesn't come into the airway. Patient may have desaturation or cyanosis, sometimes even cardiorespiratory arrest. So you have to be familiar with these symptoms. You need to know what the patient's usual respiratory status is so that you can recognize if there is a deterioration. Okay, so what to do if there is an emergency? That if you find all these red flag symptoms, that means the patient is having a tracheostomy emergency. The first thing is to shout for help, call for help, because it's easier if you have more people there to help you deal with the emergency. You can open the patient's airway and give high flow oxygen to tracheostomy and the face. So you can put a mask over the face, because sometimes the airway is patent and the patient is breathing, then you may be able to supply some oxygen to the body from the face. And also on the tracheostomy, if you have a trache mask or if you have a HME filter on, add oxygen to it. If you have a capnograph, calorimetric capnograph, you can immediately check if the color change is there, or if you have a bedside end-tidal carbon dioxide monitoring, if you can see a nice trace like this, a rectangular shape, that means the tracheostomy is in position. That is, the tracheostomy tube is in trachea. Okay. So if the patient is still struggling with this, then you have to remove all the attachments. If you have a HME filter attached for humidification, remove it. A speaking valve is a one-way valve. The patient can breathe through the tracheostomy, but breathe out through the airway, patient's airway, and this helps to the patients to talk. So it's sometimes, applied to the tracheostomy to help the patient talk and communicate and so on. If there is an inner tube, change the inner tube, but this is not usually present in pediatric tracheostomy. So once you've removed all the attachments, check if you can pass a suction catheter. If the suction catheter can be passed, that means the tracheostomy tube is patent. You perform a tracheal suction. Maybe there's obstruction with secretions which you can remove, and you continue assessment as per PALS protocol. You can't pass the tracheostomy, the suction catheter, then that means the tracheostomy is either displaced, say instead of being in the trachea, it's in the subcutaneous tissue, or it's blocked with a lot of secretions. So in this case, you have to remove the tracheostomy and replace it with a new one. So the first change you can try with the same size trachea. If it's not successful, use a smaller trachea. Okay. If you've done this and still the patient is struggling to breathe and not improving, oxygen saturation is even going down further, that means the tracheostomy is not in right place. So you have to remove it. Okay. I told you the tracheostomy stoma will remain patent even if you remove the tracheostomy tube for a few days. So it's okay, the patient can still breathe if you remove the tracheostomy tube. The stoma will be open and the patient may be able to breathe. So if you are in this situation where there is tracheostomy emergency, and you had to replace the tube, and even after replacing the patient is not improving, remove the tube and assess the patient again. As I said, the tracheostomy stoma may be patent and the patient may be able to breathe. And now the tracheostomy tube is out, the patient may also be able to breathe through the upper airway. And in many patients, even with patients with craniofacial abnormalities, the upper airway may be partially patent. So this will help oxygenate the patient and prevent the patient from going into cardiac arrest from desaturation. Okay, hypoxemia. So if this was the case that the patient can breathe, then apply oxygen to the face and also to the tracheostomy site so that the patient is now fully oxygenated. Okay. If the patient is not breathing, then you have to give 5 rescue breaths. 5 rescue breaths you can give it through the usual manner by opening up the airway, applying the mask to the face, and give 5 rescue breaths. But at this time you have to close the tracheostomy site to prevent the air from leaking out through the tracheostomy stoma. Okay, and assess the patient. If you can produce a chest rise and you can give good chest rise, that means the patient will start oxygenating and start recovering. In that case, you continue bag valve mask. But if the patient has had cardiac arrest, then you have to go to CPR and continue 15 compressions to 2 rescue breaths, usual CPR as per PALS algorithm. So if you took the tracheostomy tube out and you tried to bag the patient, give oxygen, and nothing is working and the patient is deteriorating, then you have to think about how to improve the situation, which is how to oxygenate the patient. So the 2 things you can try is you can put, if the airway, maybe it's still obstructed despite positioning, in that case, you may be able to bag the patient with an oral airway adjuvant. Either you can use an oropharyngeal airway or you can use a supraglottic airway like LMA to oxygenate to make the airway more patent and bag the patient. Don't worry if you had shouted for help and put like a code call. By this time, you should have many people around, including anesthesia and pediatric ICU, to deal with this situation. Okay. If that is not working, then you can try to ventilate the patient through the tracheostomy tube. You can either apply a small mask, like a neonatal mask, around the tracheostomy stoma, or you can use a LMA and put, pressure around the tracheostomy stoma, position it on the tracheostomy stoma, and you can try to ventilate. Okay. If this is also not working, and if there is a expert intubator, you can try intubating through the oral, like the usual laryngoscopy or video laryngoscopy, and intubate the patient from the top end. And if usually you intubate, the cuff may be sitting at the site of the tracheal stoma, and you may be able to ventilate the tube, ventilate the patient. If oral intubation is not possible, then you can try intubation of the stoma. Here you can put a 5 bougie through the stoma into the trachea, and then pass a 3 millimeter endotracheal tube on the bougie, and you can use that 3 millimeter endotracheal tube to ventilate the patient until ENT and everybody else is there. So you can use bougie, you can use fiber optic scope, airway exchange catheter, whatever is available to intubate the stoma. You can also use them, the bougie, for instance, may be helpful if you're attempting oral intubation, because sometimes you can see the lower end of the glottis, and you may be able to pass the bougie and then railroad the tube on the bougie. This is very helpful if you have a difficult airway or the larynx is not visible that easily. So all these steps can be taken to rescue the patient. Hello? How are you? Yeah. Yeah, sure. I think, yeah. Okay. In 5 minutes. Okay. Okay. Bye. Okay. A small, brief discussion on suctioning. So most of the time, only shallow or pre-measured suctioning is used. That means you don't pass the suction catheter too far into the airway. You try to pass as far as the lower end of the tracheostomy, and you suction from there. Suction pressure is 60 to 100 millimeters mercury, usually 60 to 80 for infants and 80 to 100 for children. You have to limit the suction to say 10 to 15 seconds. You have to give a gap of 30 seconds to 1 minute between suctioning episodes. Deep suction may be used if this shallow suction is not successful in removing secretions, or if you have a tracheostomy emergency, then maybe there are secretions blocking under, below the tracheostomy tube. So you may use this once or twice, but this should not be routine. Routinely, only shallow suction should be used. Sometimes it's not routinely recommended to administer saline because this will increase the risk of, ventilator-associated pneumonia. But you can use them if you find that the secretions are very thick and you have a tracheostomy emergency, you're unable to suction it, you can use it as a, if you need it, in a patient, if the secretion is too thick and you think the tracheostomy tube is blocked, and if you administer saline, it may loosen up. But it should not be done routinely because it will kind of wash out all the bacteria into the patient. Also, if you administer too much saline, this may impair oxygenation, because the water will get into the saline will get into lungs. Okay. Any questions? Jolie?
No, doctor, it's clear. Thank you.
It's clear. Omar? It's very clear, doctor. Okay. Thank you very much. Okay, I will try to. I don't know what happened with the Teams. You can still see me, right? Yes. Yeah. Where is the Teams? It's disappeared. Here. Okay, thank you very much, guys. Okay, I will try to edit this for other people to watch. Okay. Okay. Thank you for joining. Hope it was useful. Okay. Okay. Bye.